Okay. 4 years, sorry, 4 days after open reduction and internal fixation of tibial fracture, a 57-year-old woman becomes agitated. She believes that the nurses are experimented on her, are not letting her sleep. She has hypertension, SLA, no history of psychiatric illness or substance abuse. Her medications are chloroquine, hydrochlorothiazide, meperidine, propranolol, thyroxine. On mental status examination, she is oriented to person and place, but not the time. Person and place, not the time. She says that the nurses are trying to poison her. Which of the following is the most likely responsible participation syndrome?
Ready?
1 second, please.
Mhm.
Okay.
Okay, so it is meperidine. Delirium is a acute confusional state typically resulting from acute medical illness, deep disturbance, substance use medication, common medication associated with delirium, anticholinergic, opioids, benzos, and of opioid medication, meperidine and tramadol have been found to be highly deliriogenic. Delirium presents with acute disturbance in awareness, attention, and baseline conditions that fluctuate in severity during the course of the day. Patient may present with persistent may perceptual disturbance, hallucinations. Management of medication induced delirium should involve stopping the medication, optimizing exacerbating medical conditions, frequent reorientation, maintenance of normal sleep-wake cycles, placement of the patient in a calm and soothing environment. It's not chloroquine. Anti-malaria agent used to treat SLE. None of the medication are associated with the labor. Okay, next.
Okay. It, uh, a 32-year-old woman comes to the office as a new patient because of a 3-year history of constant abdominal pain, nausea, vomiting, diarrhea that have become acutely more severe during the past 2 weeks. She has She also reports constant headache, painful irregular menstrual period with heavy bleeding, occasional chest pain, pain during intercourse. She reports that I am in pain 24 hours. Sometimes her head are so intense during times of stress that she becomes temporarily blind. She states that she has been nearly dozen physicians since her symptoms started because they do not seem to know what's wrong with her. I'm really a complicated case. I need someone of your caliber and education. Vital signs are within normal limit. Which of the following is the most likely? His training is like that he's saying something in in a pattern, in a dramatic pattern. Is it histrionic?
I don't know. I think it's the only was the sexual person. That's really, I don't know. I think the person that's really sexual. I don't know.
Okay.
You're ready.
Yes.
The somatic symptom disorder. Now, I guess that. Somatic symptom disorder more likely cause of this patient pain symptoms in the setting of ongoing symptom despite extensive uh, evaluation and may be diagnosed on a site level, on a site assessment. According to DSM-5, patients with somatic symptoms are preoccupied with existing somatic symptoms such that these symptoms disrupt the daily life. Somatic symptoms are thought, 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 thought present the unconscious conversion of psychological state to somatic symptoms. As such, a trauma history is common. These symptoms may or may not originate from underlying disease, tissue damage, and may or may not be accompanied by mood or anxiety disorder diagnosis. Patients with somatic symptoms is also persistently devote excessive time and energy to these symptoms or related health concerns, repeated going to the doctor. Somatic symptom disorder typically demonstrates a chronic and fluctuating course. Management of somatic symptoms are regular PCP follow-up that target skill provides you assurance and avoids unnecessary tests. Functional neurologic symptom disorder involves neurologic symptoms such as sensory or motor dysfunction that are not fully explained by objective findings on physical exam or imaging. Common example include blindness, aphasia, and explained weakness. Functional neurologic symptom is postulated to represent the subconscious conversion of intolerable emotional distress into neurologic symptom. Histrionic, characterized by theatrical, superficial expression of emotion that unconsciously serve to gather attention from others to fulfill emotional needs. May have a may behave seductively. These patients attend to gain blah 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 using pain, not seduction. It's not illness, anxiety disorder. It's characterized by excessive anxiety and preoccupation about the possibility of having or acquiring a serious illness, so that patient performs frequent health related behavior, repeatedly going to the doctor, or exhibit maladaptive avoidance, completely avoiding going to the doctor, which persists for at least 6 months. This patient is preoccupied with her resistant pain symptoms, not the possibility that she may have a serious illness. It's not psychological factors affecting medical condition refers to psychological or behavioral factors that exacerbate the medical condition interfere with its treatment. Those psychological factors contribute to the generation of somatic symptoms. No medical condition has been identified. Okay.
Next.
Next.
A 74-year-old widower comes to the physician because of gradually increasing insomnia for past 2 years. She has to she has to bed at 11:30 a.m. and awakens at 5 a.m. He sleeps soundly except for awakening to go bathroom once during the night. He is concerned because he used to sleep at 8 hours daily. He is active and presents his own meals. Medications include ranitidine at bedtime for GERD and verapamil for hypertension. His pulse is today is 88 per minute, blood pressure 160 by 88 millimeter mercury. He appears mildly anxious. Examination shows no other abnormal. Which of the following is the most appropriate next step in the management? Okay.
Ready? Okay.
Yes.
It's reassurance that the patient's sleep pattern is normal for age. Older adults typically experience several sleep-related changes as they age, a slight decreased total sleep duration, sample at 6.57 hours, slightly increased sleep latency, Increased nighttime awakenings, 3 nights is not 3 times per night. An increased proportion of time spent in deep sleep and REM sleep are typical. The increase in time in nighttime awareness can be attributed to less time spent in deep sleep and nocturia. Management should include reassurance and counseling on sleep hygiene can help optimize their sleep pattern. Next,
Which of the following is the most likely diagnosis? A 37-year-old physician because he is worried about speaking at a convention in few weeks. He reports that he ruminates constantly about disappointing his boss. He says that when he practices speech, he blushes, has sweaty hands and a racing pulse, and feel embarrassed. He does not go to the parties or date. He is uncomfortable talking with the people, but he does not know. But people he does not know. He says that he feels conspicuous eating at restaurant because he imagines that other patrons are amused by him. He has difficulty in signing checks and finger lip and extensively written results are shown. Results of the lab are shown with the reference range. Which of the following is the most likely diagnosis?
ready?
Yes.
Social anxiety disorder. Social phobia refers to an excessive fear of scrutiny, embarrassment, or rejection in a social or performance situation, leading to significant distress and or a painful functioning. Patients with social anxiety disorder commonly exhibit shyness and performance anxiety. Performance anxiety refers to the fear of negative evaluation in situations such as public speaking, test taking, and sex. Patient fears about performance may extend to other public rituals such as eating. Patients with social anxiety disorder may experience um, so it may anxiety disorder may experience decreased anxiety when interacting in more intimate settings or with familiar people compared with socializing in groups or with strangers. Body focused behavior and beating are common in patients with anxiety disorder. Treatment typically involves cognitive behavior, CBT, and antidepressant SSRI and also include as needed anxiolytic medication. Wait. So performance anxiety is a type of social anxiety. Okay. And it's not agoraphobia refers to fear of leaving one's home, though the patient reports fear of being negatively evaluated for public behavior. He does not specifically have fear leaving his home. And it's not generalized anxiety. Anxiety disorder that feature excessive worry about a range of topics. Where am I? With psychological and physical symptoms and associated functional impairment. This patient anxiety is specific to social situation. Okay, next.
Okay. A 26-year-old woman comes to the emergency department because of a broken arm. She says happened from a fall she sustained. The patient's medical record shows that his third visit to the emergency department for the past 3 months. The previous two visits for broken ankle and the concussion. When he asked about her recent injuries, she stated, "I'm sorry, but I'm so clumsy." She states that she used to go to work as a teacher but he stayed home since the birth of her third child 8 months ago. She says that the loss of her income both a significant financial strain and a form or family history requires her husband to work two jobs. He has no history of psychiatric illness, significant medical history. His mood is mildly anxious, and she often looks at her husband before answering any question. Physical examination shows swollen right forearm, severe bruises on the upper extremity, and this. When asked about these bruises, the patient says she is often bumps into things. Which of the following is the appropriate course?
Ready?
Okay.
Is develop an emergency safety plan with the patient. Domestic abuse or intimate partner violence, the most likely explanation for the patient. Distribution of reason and frequent injuries and coming to the ED. And domestic abuse should be considered in patients with suspicion pattern and bruising and or explanation of for mechanism of injury that are inconsistent and do not match physical exam. Areas of bruising that are particularly worrying include the lower abdomen, posterior ribcage, head. Forehands may become bruised while employing defense movements to prevent injury to the face or torso during attack. Risk factors for domestic abuse with recent job loss or job financial instability and substance use. Domestic abuse often increase or begins during pregnancy, especially during a pregnancy. All patients with physical findings suspicion for domestic should be asking a tactful or non-threatening manner if they feel safe at home. If possible, patients should be assessed alone to prevent intimidation that may occur when the partner is present. If patients express that they are being abused, it is the provider also to assess whether they are prepared to act. Often patients are not willing or able to leave a violent relationship. Understanding this requires empathy on the part of the doctor. However, all patients should receive assistance with with developing a safety plan, which include identifying a place to flee if necessary, developing and relying signals or call words to children or neighbors who can call for help, and preparing emergency kit stored outside the home with necessary items that might be required if the patient needs to run away. Written patients material such as pamphlets should generally be avoided as this can be discovered by the abuser. Many states require mandatory reporting for abuse of children, elderly, and disabled persons. The requirements for abuse of adult varies by state. Next.
A 59-year-old man comes to the office 6 month history of increasing difficulty and erection during sexual intercourse. 1 year ago, he was diagnosed type 2 diabetes mellitus. He also has 40-year OCD. Medications are sertraline, clomipramine, risperidone, metformin. He has been married for 28 years. The patient drinks 5 beers weekly. He is 190 centimeter tall. Weight is 97 kg BMI, 27 kg meter square. Temperature 70, pulse 72, respiration 10, blood pressure. Physical examination shows mild gynecomastia. Which of the following is the most likely cause of this patient's symptoms?
Hmm. Between risperidone and sertraline. But does risperidone cause sexual dysfunction?
Not really.
Not really. I
SSRI
think
can
it's,
cause
but does is SSRI cause gynecomastia also?
that thing. I am confused.
Because I know risperidone causes the prolactinoma.
Hyperprolactinemia, but hyperprolactinemia is not gynecomastia, is it?
It's not gynecomastia. So you think this is a distraction that they gave?
Probably.
Okay, ready. Nope, was not a distraction. They were trying to do risperidone. Damn it. Risperidone is an antipsychotic medication used in refractory OCD that acts as a D2 antagonist. It antagonizes dopamine midzoline whatever, corresponding to improvement of psych symptoms. Oh, it also has serotonin thing. Never mind. Improvement of psych um, symptoms, worsening staphylococcus symptoms, and sexual dysfunction repeatedly. In the tuberoinfantibulopathic power, the phenylatonin leads to hyperprolactinemia manifesting as gynecomastia as in this patient in galactorrhea. Of the antipsychotic medication, risperidone is especially well known for causing hyperprolactinemia. Prolactin suppresses gene RH, which decreases release of LH and FSH in females, leading to gonadal dysfunction. In males, decreased testicular release of testosterone, okay, leads to erectile dysfunction and decreased libido. In females, decreased ovarian release of estrogen is associated with amenorrhea and infertility. If antipsychotic-induced hyperprolactinemia is asymptomatic, then no changes are needed. In the case of symptomatic hyperprolactinemia, as in these patients, option includes stopping the risperidone, adding dopamine agonist or partial agonist, and or adding testosterone. It's not sertraline can commonly cause sexual dysfunction within all three phases of sexual response, like libido, sexual organ. Growth is teratogenic effect. However, gynecomastia, which is typically mediated by hyperprolactinemia, will be uncommon. Mm.
Next, an 8-year-old boy is brought to the physician because of 3-month history of falling asleep during school. He has mucopolysaccharidosis and attends special education classes. His teacher notes that she has been asleep. She has been asleep at desk on 2 occasions and concerned that he may have unwitnessed seizure. He has hyperactive aggressive treated with haloperidol. He relieves diphenhydramine. Sorry, he also receives diphenhydramine at bedtime. Fall asleep. His prawns are numb. Examination shows multiple joints and contraction of the facial feature of the hair, which are the following most likely next step.
Ready?
Yes.
Polysomnography. Polysomnography used to diagnose OSA, which is, I guess, what the patient has. Headaches that occur in the morning and frequently reported by patients with untreated OSA. This patient is highly experiencing sleep-related hypoventilation with OSA. Clinical features of OSA include excessive daytime fatigue, falling asleep at inappropriate times, loud snoring, and disrupted sleep fixation. Sleep wake cycles. These factors include male, obese, congenital or traumatic anatomic abnormalities of the oropharynx and neuromuscular disorder and use of sedative medication. Untreated OSA is associated with hypertension. Management commonly involves adenocarcinoma surgery for cases with obstructing lesions of the airway through sleep apnea secondary to those sleep apnea secondary to mucopolysaccharidosis can also require well to enzyme replacement therapy. Mucopolysaccharidosis are a type of lysosomal storage disorder caused by an enzyme deficiency that prevents the degradation of glycosaminoglycans into lysosomes, leading to cellular dysfunction. Patients with mucopolysaccharidosis typically demonstrate progressive CNS degeneration, developmental delay, behavioral dysregulation, skeletal abnormalities like facial features, joint contraction, and hypotension. Sleep disorders such as sleep apnea are common. It's not B, what is B and C? Wait, B and B. It's not EEG may assist diagnosis seizures. However, this patient does not demonstrate evidence of seizure like postictal confusion. The patient's incidence of sleeping at his desk is likely due to ulcer. CT scan of the head are helpful in identifying hydrocephalus, a complication of blockage of arachnoid granulation, blah, blah, blah. Patients may present with morning headache and other signs of increased intracranial papilledema, visual disturbance, progressive neurological dysfunction. Other than morning headache, this patient has no other signs of hydrocephalus. Next. Oops, sorry.
Okay. Which of the following is the most likely explanation for these findings? An 82-year-old man comes to the physician for a routine examination. For the past 2 months, he has felt fatigue and slept 4 to 5 hours nightly. He has stopped taking in crunch and social activities. He reports that his appetite is pretty good, but often he just cannot taste the same. He has 2.3 kg of weight loss since his last visit 6 months ago. The patient has hypertension, benign pulmonary hyperplasia, peptic ulcer disease. Current medication included current medication include ranitidine, terazosin, hydrochlorothiazide. He is 185 centimeter tall and weight is 70 kg. BMI is 20 kg per meter square. His temperature is 37 degrees Celsius, pulse 80 to 100, regular, respiration is 18 per minute, and blood pressure is 160 by 96. Examination shows 1 plus edema, mild tremor. The remainder of the examination shows no abnormality. He speaks slowly and softly, prolonged response latency, and has a difficulty in concentration. Although his mood is non-reactive, he is oriented to person and place. He knows the month, year, day of the week, but not the day of the month. He recalls of 2 out of 3 and can draw an intact recall. Which of the following?
Oh, ready?
1 second, please. Okay.
So it's MDDO. Okay. MDD. This patient meets criteria for MDD is characterized by 2 or more weeks of at least 5 of the following: depressed mood, anhedonia, um, guilt, worthlessness, difficulty concentrating, micromotor slowing, suicidal thoughts, and neurovegetative disorder like decreased energy, sleep disturbance, appetite disturbance. These symptoms disrupt everyday functioning. Some in the mental examination findings commonly include depressed affect with decreased affective range for eye contact, response latency, and distractibility. Mild abnormalities on cognitive testing may be present. Particularly in outpatient, this patient should be carefully assessed for suicidal ideation and suicide trauma. The most effective treatment is psych and antidepressant medication. It's not mood disorder secondary to general medication. It's unlikely in this patient. General medical condition. Physiologic tremors, action tremor, and mild pedal edema are relatively common in all patients and typically do not suggest a serious medical illness. Normal aging includes a slow decline in executive functioning, processing speed, and episodic and working memory, attention span, and problem solving. MPP is not part of normal aging. Okay. Next.
Okay. A 52-year-old man is brought to the emergency department by police because of strange behavior after he was arrested for disturbing the resident in his neighborhood. For the past 6 months, he has been aggressively advertising for his new age healing business by disturbing leaflet. He runs the business from his house and claims that he has special abilities to cure all kinds of physical and mental ailments. Um, he is not extremely upset, but he is extremely upset about arrested and believes that people are and believes that the physician and police are conspiring against him. He says, "You don't understand, Doc. I really have special powers. I can heal all the people waiting room." He says that he has not psychiatric problem. Okay, which of the following is most likely diagnosis?
Mm. Ready?
1 second, please. Okay.
Okay, so it is delusion. Oh, shit. Delusional disorder. Not see that one coming. Delusional disorder is a psych disorder that features the presence of one or more delusions for 1 month or longer with no psych symptoms like hallucination, disorganized thinking, disorganized behavior, other than behaviors related to the disorder, to the delusion, or mood symptoms, no psych symptoms, no mood symptoms. Persecutory delusion, as in this patient, and somatic delusion are common type of delusions. Many times, patients will only present for care at the insistence of other people, giving the lack of insight into the psych nature of the concern. Treatment typically includes antipsychotic meds and psychotherapy with the goal of improving the patient coping with the delusion and gradually increasing insight into the delusion. The prognosis is guarded. It's not bipolar. Bipolar disorder characterized by discrete episodes of depression and mania, which can sometimes be accompanied by side symptoms such as hallucination and delusion. If patient does not report mood symptoms like depressed or euphoric mood, um, increase or decrease sleep. Okay, that makes sense. Schizoaffective and schizophrenia are chronic psychotic disorders characterized by delusional hallucination, disorganized speech, disorganized behavior, and negative symptoms like alogia, apathy, flat affect. Schizoaffective disorder also includes significant mood uh, episodes like MDD and manic episodes. This patient demonstrates an isolated delusion with no disorganized speech, thinking, hallucination, and negative symptoms.
Okay. Next. A 10-year-old boy is brought to the physician as a new patient for routine health maintenance examination. His mother reports that he was diagnosed with mild autism. He was diagnosed with mild autism at the age of 4 years. He has no notable for this concern. He's a, he attends special classes in the public health and has mild intellectual disability disorder. She adds that he has a maternal cousin with similar symptoms. Physical examinations show large ear, head, and testes. Which of the following is the most likely cause of this patient? Large microdysm.
Ready?
Yes. Okay. Is it
Is Victimar one gene, patient constellation of finding intellectual disability, long face, ears, and testes suggestive of fragile X syndrome. Patients may also present with hyperextensible joints and high arch palate. Fragile X syndrome's second cause of inherited intellectual disability after Down and is inherited in X-linked dominant pattern. So boys, it's caused by um, CGG trinuclear repeat in the FMRY gene on the X chromosome. On karyotype, the end of the X chromosome are phase truncated, leading to fragile X syndrome. Patients with fragile X syndrome are increases of mitral valve prolapse and educational difficulties. They are often diagnosed with autism as with all trinuclear repeat expansion genetic anticipation is seen where a future generation blah, blah. It's not, let me see what is the MECP2 gene is Rett syndrome, regression of developmental milestones occurs in females after an initial normal development. Patient suddenly develops low speech capability, motor skills, and stereotypical hand movement, gait abnormality, and developmental delays. It's not microdeletion of chromosome 7, which is seen in Williams syndrome. It presents with an overlay friendly demeanor, emotional dysregulation, and intellectual helping faces. Short stature, vascular and cardiac anomalies secondary to elastin dysfunction, structural abnormalities of the urinary tract, and endocrine abnormalities, hypothyroidism. Next.
okay? Can you give me 5 minute break?
Yeah,
Okay, I'm coming.
it's my in health and all these things.
Sorry,
It's like pretty
what
annoying.
what you're
You
talking?
didn't see the changes that they are having at ECFMG. They are doing changes like everything is going to switch to my in health. You won't have the Oasis and ECFMG. Everything is going to be, well, the way I understood it. I'm not sure if I understood it well, but everything is switching to a new app that is called My In Health or something like that.
I don't know that.
What? It's like all over the place since like yesterday. They announced it that everything is going to be down from August 14th. Everything will be down for like a week because they're trying to switch everything to this new app that is called My In Health. They changed the prices of the exams. Like I think like the USMLE is not going to be like $1,000. It's going to be like 600. And then the ECFMG certification is not going to be like 100. It's going to be like 500. Like they're changing. I don't know.
Like
It's been
like the price is
the prices
reducing.
are changing. Not some of them are going up. Some of them are reducing. Um, like yeah. So people
Maybe
are like,
maybe Trump found a new idea to make
I
money.
don't even know why they're doing all of this right now. And some people are trying to apply for the exams. And they're asking, like, should I apply now? Should I wait until after August when the thing everything changes? So it I don't know. So I know I applied like 2 weeks ago for my permit and it keeps saying like I called them was it 2 days ago and they were like it's still being processed. I'm like I needed to be processed before you guys started doing your changes, weird changes there. Because, yeah. So
Okay.
I'm like, there's so much change happening right now. I don't like this. Like, I don't know. I don't know. I don't like change. I get nervous. Um, I
Change
get
will
in.
in US everything is changing. Like
I know, but when it doesn't affect you, you don't feel it. But when it's something close to
it
you.
it will it it will affect everybody. The how the things is changing in the United
Yeah.
States. Everybody will suffer.
So I'm like,
It
why?
is my assumption. I don't know. Like
Why
they
are they
are
coming
they
to?
are cutting costs in the health sector.
Yeah.
They are
Because
cutting cost in the uh, research. Not the
yeah,
thing.
yeah,
So if they will cut cost on health sector or in research, maybe the you know that the US physician paid highest in the world. So if
mhm,
they start cutting these things, then people will lose interest in US only. Why they came there? Because of money, isn't it? Money and respect. Okay.
because a lot of like could have waited until this season, like this application thing ends, and then they can do all these changes. But you come in and do the changes now when people are trying to take their exams quickly before the thing
Yes,
starts, new season
maybe.
starts. It's crazy. And then the pathways usually they open in June
Like
or like
when the pass fail starts.
they
Eh,
haven't opened. Nobody knows right now because usually it opens in May, June, but they haven't opened. And then somebody said that they called was it ECFMG whatever they called them to ask them, hey, what's up with the pathways? When are they going to open? Because I already have all my step to everything. I just need the pathways to be able to apply for ECFMG. And then the customer service at the ECFMG told them that because they are implementing this new My In Health thing, they don't know when the pathways are going. They have to first implement that thing before the pathways open. So it's like pathways is probably going to open in August, end of August, and you have to submit your application for errors in September. So it's going to be like tight. Like people will have to run to get the pathways in. So it's like wow, like this is crazy. This is not the time to do all these changes. You could have waited like after March next year, like after March or something, April, something.
okay.
Anyway,
They will
sorry
not
about
gonna
I
listen
had,
to us.
sorry, I had to vent because I was anxious.
No problem. A 24-year-old woman is brought to the emergency department 30 minutes after she was involved in a motor vehicle collision. She was the restrained front seat passenger in a car that was struck from behind by a truck traveling at 5 mph. She remembers no significant jolting of her body as a result of the collision. 10 minutes after the collision, she developed weakness and loss of sensation on the left side of her body. Examination showed decreased visual acuity in the left eye, sense of hearing, olfactions, and tastes are decreased on the left side. She does not voluntarily move her left side of the face, and she has no voluntary movement of her left extremity. Deep tendon reflexor 2 plus bilaterally in all extremity. Babinski sign is absent. Sensation to vibration is decreased more on the left side of our forehead than on the right. Which of the following is the most likely diagnosis?
Jesus. The hell? Hmm. Ready?
Yes.
It's conversion disorder, also known as functional neurological symptom disorder, involves neurologic symptoms such as sensory and motor dysfunction that are not fully explained by the objective finding on physical exam or imaging. This patient demonstrates midline splitting of sensation of sensing vibratory, midline splitting of sensing vibration on the forehead, symptom that cannot be localized and therefore represents a classic symptom of conversion disorder, along with facial paralysis that does not spare the forehead, which is associated with Bell palsy rather than CNS lesion. Finally, left-sided limitation and semisensory deficit included left-sided facial motor and associated back slapper, and sensory deficits cannot be localized. Breaststem lesion typically lead to ipsilateral cranial nerve dysfunction with contralateral dysfunction of the body. Conversion disorder is postulated to represent the subconscious conversion of intolerable emotional distress into neurological symptoms. The pathogenesis likely involves a top-down amplification of symptoms secondary to abnormal processing of negative emotion. Physicians should conduct a thorough history and physical exam as well as obtain lab imaging studies to evaluate for medical or neurologic disease that may explain or partially explain the symptom when diagnosis is unclear. In traumatic or emergency settings, the diagnosis is one of exclusion, treatment, or conversion disorder. It involves education about the diagnosis, physical therapy, CBT. It's not carotid artery dissection, which can occur secondary to whiplash injury, commonly leads to ischemic stroke and carotid sinus syncope, secondary to pressure against the carotid sinus spiral receptors. However, this patient does not demonstrate localized or pattern of neurological deficit or syncope. It's not vertebral artery dissection, which rarely occurs secondary to whiplash injury, commonly leads to thromboembolic strokes of the posterior circulation. Patients typically present with vestibulocerebellar signs such as ataxia, dysmetria, dizziness, imbalance, vertigo, blah, 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 ipsilateral cranial nerve dysfunction, contralateral hemiparesis, contralateral decrease in pain and temperature, contralateral monomos hemianopia with macular sparing, and or Horner syndrome. This patient has vestibulocerebellar signs, and neurologic symptoms are ipsilateral. Okay.
Next. A 37-year-old woman comes to the physician for advice about a weight loss program. She has a history of MDD. Her last episode was 16 months ago. She was treated with bupropion until 7 months ago. She currently takes no medication. She has been employed as bank manager for the past 10 years. She was wearing multiple rings on each hand and has four piercing in each ear. She states that six of her piercing were done in the past 3 weeks. She is 160 centimeter 5 feet 3 inch tall. Weight is 54 kg. BMI is 21 kg per meter square. Physical examination shows no abnormalities. On mental status examination, her eye contact is intense and speech is pressured. She says, "Your nurse tells me my blood pressure and Weight are perfect, but I want to make some changes in life, including slimming down. I have become bored at the bank. I know your sister is a designer. I love design. Can I call her and ask her when I can get top-notch training? Which of the following is the most likely diagnosis?
Ready?
1 minute.
Yeah.
Is it bipolar?
I think so.
Okay.
Bipolar. This patient, what is it? This patient is still of recurrent depressive episode is presenting with new onset hypomanic symptoms consistent with diagnosis bipolar disorder. Bipolar type 1 is a mood disorder featuring acute episodes of mania and depression. Bipolar 2, mood disorder featuring depression and hypomania. Patients with bipolar 2 bipolar disorder commonly present initially with depression and may be provisionally diagnosed with MDD before experiencing hypomania for mania, revealing the underlying bipolar disorder. Acute mania manifests with 4 to 5 of the following irritable euphoric mood, increased goal-directed activity, increased energy, decreased need for sleep, rapid speech and thinking, grandiose thinking, hypomanic episodes are like many but less severe and do not markedly impair social functioning or require hospitalization. These patients demonstrate pressure speech, impulse behavior outside of normal behavior, multiple pacing, grandiose thinking, and rapid thinking, and increased goal-directed activity. Management of acute hypomania typically requires mood stabilizing agents. Where am I? No stabilizing therapy, like no stabilizers or atypical antipsychotic. It's not psychotypic. Hypomania and depressive symptoms that fail to meet criteria for hypomanic or depressive episode. This patient meet criteria for hypomania episode and she has history of major depressive disorder. Okay. Next.
Yes. A 40-year-old woman comes to the physician because of one history of severe anxiety palpitations and the sensation of racing her 2 months ago. She has 2 months ago she had the onset of anxiety and insomnia. mm, At the onset of anxiety and the insomnia after she and her husband separated. She received a prescription for lorazepam at the time. She reports that the medication calmed her and helped her sleep. She says she occasionally took extra pills and finished the prescription before she could obtain a refill. She has no history of serious illness, takes no medication. She does not drink alcohol or use illicit drugs. She is diaphoretic. Her pulse is 90 per minute, respiration 16 per minute, blood pressure 140 by 90 millimeter mercury. Physical examination shows bilateral hand tremor. On mental status examination, she has an anxious mood and irritable affect dysregulation of the following neurotransmitter is which of the following condition.
Ready?
1 second. They are asking which one's mechanism.
Ah, I can't hear you.
Sorry,
I can't hear you. What did you say?
like they are directing on which mechanism. Okay, let's see.
So it's GABA. Benzo, such as, I guess they were asking what does benzo affect? What the neurotransmitter benzos
Okay,
affect? Increase the CNS activity of GABA, the main inhibitor neurotransmitter. Abrupt discontinuation of benzo that leads to excess excitatory pathways. Benzo withdrawal typically presents with tremor, anxiety, restlessness, headache, nausea, diaphoresis, which can occur hours after cessation. Withdrawal is managed supportively with benzos to address agitation. Okay, so you give benzos to stop withdrawal. Okay, and prevent the symptoms of withdrawal. IV fluids, nutritional supplementation, and frequent assessment, including vital signs. Other complication of benzo withdrawal includes hallucinations, like hallucinations, without autonomic stability or confusion, and seizures. Okay, next.
yes. A 37-year-old woman comes to the office because of 2 month history of constipation. During this time, she has had two bowel movements weekly. They are uncomfortably hard and require straining. Prior to 2 months ago, her bowel movements were normal. The patient says she is in the midst of a divorce and has not been sleeping well because of stress. She has no fever. She has no history of illness. Her only medication is diphenhydramine as a sleep aid. She she follows a well-balanced diet consisting of at least 4 servings of fresh fruit, vegetables daily. The patient does not smoke cigarettes, drink alcoholic beverage, or use illicit drug. She appears anxious. She is 170 centimeter tall, weight is 64 kg, BMI 23 kg per meter square. Vital signs are within normal limits. Physical examination shows no abnormal. Which of the following is the most appropriately active in the management? Ready?
Yes. A discontinuation of the diphenhydramine. This patient likely experienced constipation as an adverse effect of the diphenhydramine. Though stopping that is the next step. Diphenhydramine is an antihistamine with anticholinergic activity used in the treatment of allergic reaction and off-label for anxiety and insomnia. Endogenous acetylcholine binding to muscarinic receptors causes smooth muscle contraction in sweat glands, salivary glands, airways, bladder, and bowel. Cholinergic neurons projecting to the cerebral cortex mediate attention, learning, memory. Antagonism of muscarinic acetylcholine receptor blocks cholinergic signaling in the brain and causes dysfunction of smooth muscle contraction, leading to cognitive impairment, delirium, sedation and hydrosis, dry mouth, bronchospasm, urinary retention, and constipation. Common constipation symptoms include having fewer than 3 bowel movements per week, passing house training, could defecate and experience abdominal bloating. Medication cause bothersome or severe constipation. The offending medication should be stopped. Next.
Yes. A 27-year-old man with schizophrenia comes to the physician for haloperidol injection. He receives every 3 weeks. He is cooperative and friendly, but appears anxious and jittery. He says that he has been hearing voices more frequently over the past week, and this is affecting his job's performance. He works in a local sheltered workshop and lives with his parents. 10 days ago, he got to an argument with his parents about the illness. They repeatedly tell him that he needs to be get regular job. He will never amount to anything. They says that the voice he hears are excuse but not to meet new people, and he will never they can worry about he will never marry, and which of the following is the most appropriate intervention? Okay.
Ready?
Yes.
It's recommend begin family therapy. According to DSM-5, patients with schizophrenia demonstrate at least two of the following five symptoms: delusion, hallucination, disorder, night speech, behavior, negative symptoms. To meet criteria, patient may demonstrate functional deficits, and the total duration must exceed 6 months. Family conflict and other psych stressors are risk factors for worsening psychosis. Stress can increase patients' negative interpretations and hallucinations. Uh, Stress can increase patients' negative interpretation and hallucination and decrease patients' emotional resources for effectively coping with side symptoms, impacting the daily functioning. Treatment of schizophrenia requires antipsychotic medication, though adjunction psych support, including family therapy, CBT, and social skills training can be beneficial. Family therapy focuses on psychoeducation, encouraging mutual understanding, effective communication, and teaching skills for the patient and family to cope with the situation. Recommended partial hospital program is not necessary currently, but the patient should address factors impacting the patient's symptoms and functioning on an outpatient basis, such as discontinuing haloperidol and beginning clozapine is not necessary currently. This patient family conflict, the immediate stressor that correlates with the psychotic is that they should be addressed first. Following this, the physician should consider increasing the dose or frequency of alloperidol. Next.
Okay. An 82-year-old man with end-stage renal disease is brought to the physician because he wants to discontinue hemodialysis therapy. He says his quality of life has declined since he entered a skilling nursing facility 6 months ago. He has type 2 diabetes mellitus hypertension, spinal stenosis. His medications are metformin, lisinopril. His wife and children live nearby, and his wife visits him daily. He has designated his eldest son, who is an attorney, as durable power of attorney for health and the estate decision. Ready?
Yes. Is discontinuing modalities. Physicians should respect patient autonomy. This principle is especially pertinent when the patient is an adult without evidence of psychomedical condition that impair basic decision-making capacity. Though patients may make decisions, physicians they must call medical judgment. The ethical principle of autonomy dictates that patients have the right to make this decision. Coercive treatment is only warranted when patients experience medical or psych conditions that interfere with their ability to make decisions. This patient has intact cognitive function and appears to possess decisional capacity to end modalities, and that he is able to appropriately verbalize his reasoning. Next,
Okay. A 30-year-old woman, a 30-year-old woman comes to the office because of 6 month history of a mole on her left shoulder that she fears could be malignant melanoma. She noticed the mole looked different yesterday. This is her fourth visit during the past 6 months for the same concern. Previous examination one was if the mole has disclosed any abnormality. The patient acknowledges the negative pathology report for the biopsy, but he says they must have read it wrong or lost my result. She visually checks her moles several times, make sure that are not changing in the shape and the size. She has had any difficulty in falling asleep, excessive worry, similar concern of okay, dermatological examination, which of the okay. Yes.
with illness, anxiety, a disproportionate fear of serious disease is consistent with illness anxiety. According to DSA, patients with illness anxiety disorder demonstrate excessive anxiety and preoccupation about the possibility that they may have or acquire serious illness, such that they perform frequent health related behaviors like going to the doctor frequently or exhibiting maladaptive avoidance like avoiding the doctor. This preoccupation persists for at least 6 months. Management centers around regular PCP follow-up evaluation that tag in copy skill provides reassurance and avoids unnecessary testing. It's not B. Generalized anxiety is anxiety disorder that features excessive worrying about a range of topics with psych and physical symptoms and associated functional impairment. Um, this patient worry is specific to the possibility of having a serious illness. Okay. Next.
Yes. A 50-year-old man is brought to the emergency department because of speech difficulty and inability to walk. She is mildly agitated, not oriented to place, and is uncooperative. According to the husband, she has been taking lithium for 20 years for bipolar disorder. Recently, she was Sorry, recently she has been complaining of increasing harsh than the urination. There is no family history of the renal disease endocrine disorder. Height is 5 feet 3 inch. Weight is 77. Blood pressure 110. Okay. There is speech difficulty. There is speech difficulty. And muscle weakness and above the cognitive function. Sodium 150, potassium 5.5. Specific gravity 1.0005, ion osmolarity 200. Ready?
Yes, yep. Is lithium induced diabetes insipidus? Um, what is it? Nephrogenic DI commonly acquires secondary to electrolyte disturbance of meds like lithium that render the renal collecting system insensitive to ADH. Former ADH triggered the insertion of aquaporin channels into the collecting blood. Over time, lithium concentrates within the cells of the collecting that interface with the signaling pathway leading to limited aquaporin insertion and compromising the ability of the kidney to retain free water. Dehydration results as found in this patient along with symptoms of polydipsia, polyuria, incontinence. In severe cases of dehydration, vital signs may show tachycardia, hypotension. Physical exam is generally unremarkable, apart from potential signs of volume depletion like weak pulse, indenting, arterial metastatic. Lab studies show increased serum osmolarity, hypernatremia, and inappropriate diluted urine. Normally, urine should be concentrated in states of hyperosmolar serum as the main physiologic function of ADH to reclaim water, thereby maintaining serum osmolarity and sodium balance in the plasma volume. Desmopressin ADH analog is used as means of differentiating nephrogenic from central DI. Central DI occurs due to absence of ADH, not the failure of the renal of the kidney. If urine output and serum osmolarity decrease following desmopressin administration, then central DI should be investigated. No change in response to desmopressin indicates that the cause of DI is nephrogenic. The treatment of nephrogenic DI includes volume repletion plus thiazide diuretics. It is not C. Where is it? Lithium-induced hypothyroidism occurs as many as 50% of patients being treated with lithium within like 1 to 2 years of beginning treatment. Hyperthyroidism and autoimmune thyroiditis may also occur. While this patient TSH is increased, hypernatremia, polyuria, inappropriate diarrhea are characteristic of DI, not hypothyroidism. Routine side effects due to lithium treatment include tremor, nystagmus, polyuria, mild thyroid dysfunction. While this patient does have polyuria, her dehydration, alternative hypernatremia, and appropriately dilute urine are concerning for a potential life-threatening condition should not be dismissed as routine. Okay, next.
Okay. A 52-year-old male old man comes to the office because of 6 month history of tingling and numbness in his feet. He has no history of serious illness, takes no medication. He does not exercise regularly. He does not smoke cigarette. Drinks 6 to 8 12 ounce beers nightly during the hot day. He knows that he should not drink less and has tried to limit the drinking because he has not been able to go more than a week. Um, without drinking alcohol beverage. He attended a single meeting of drinking. What's the key point here? Like what
I
what
think they're trying to ask, I don't know what they're asking. They're asking what
what's
is the
our
best.
target to diminish the tingling and numbness?
Oh, I thought it was how to stop him from drinking. Okay, maybe I'm wrong. I thought we were trying to stop him from drinking.
You are thinking about disulfiram.
Or naltrexone, I don't know, one of the two. But maybe, yeah, maybe you're right that the key is to
Maybe you are
stop.
right.
Oh, okay, let's check.
Naltrexone, opioid, naloxone, naltrexone.
Naloxone, peer antagonist. Alcohol use disorder refers to an addiction to alcohol that must meet these two criteria: an ability to cut back on drinking, drinking more than expected, excessive time spent drinking, alcohol cravings, persistent drinking despite physical or mental problems related to drinking, or persistent drinking despite negative social consequence. Though patients with mild alcohol disorder may rely solely on psychosocial support such as 12-step program, patients with moderate to severe alcohol use disorder or patients unable to access or tolerate psychosocial support may benefit from daily medication. Commonly used medication for alcohol use disorder include naltrexone, acamprosate, disulfiram, gabapentin. Oh, gabapentin. Naltrexone, a long-acting opioid antagonist, blocks the rewarding effects of alcohol drinking and thinking about alcohol, thereby preventing alcohol cravings. Naltrexone can be used in conjunction with alcohol and is can be used in conjunction with alcohol and is therefore helpful for patients like this interested in moderate their drinking but unsure whether they want to quit. Okay. It's not TCA and antidepressant used in MDD and anxiety disorder. They are not helpful in alcohol. And it's not the sulfiram inhibits alcohol dehydrogenase causing acetaldehyde accumulation, which leads to unpleasant physical effects, including headache, nausea, fatigue, vomiting, tachycardia, blah, blah. It is helpful in patients who are motivated to stay sober from alcohol, but no patients who are unsure about completely completely discontinue the alcohol use. Okay.
Okay,
Next.
next. A 37-year-old man comes to the physician because of bizarre incident that started 2 weeks ago. His symptom began after his supervisor fired him even though he expected to receive a promotion. A security guard accompanied him while he clenched his desk that then escorted him from the building. He then went to the bar, had 6 drinks over the last 4 hours. He felt the people he felt that the people in the bar knew he had just been fired, and while looking at him and talking about him, these feelings persist. When he moved awake in the next morning, he closed all the curtains he closed all the curtains in the apartment and tried watching television, but he thought the people of the television were mocking at him. Past over the next week, he had heard male voice telling him he was a failure. Okay. How many years? How many years? 7, 6.
Jesus. Oh no.
Very confusing
It is like
what they are
so.
thinking.
I'm between A, B, and F. Adjustment disorder because he just had a bad event. Brief psychotic because it's less than a month. Okay, brief psychotic. And then substance induced because he drinks. He says that he started when he drank, then he continued the next day. I guess he wasn't drunk anymore. Blah, blah, blah. By the end of the week, he had resolved, but he drinks 2 to 3 beers each night. I guess that's not that much drinking, I guess. I don't know. I'm between A, B, and F. Brief psychotic. No hallucinations. But he had some man telling him that he had whatever. I don't know. I don't know. I don't know. Get the next week. I hate those kind of questions. Next, disturbance of emotion and conduct. Okay, I'll go with A. Probably B or F. Ready?
Yes,
Yes, B. B psychotic disorder. Oh, this is crazy. This patient meets diagnostic criteria for brain psychotic disorder. Brain psychotic is characterized by acute onset of one or more psychotic symptoms lasting less than a month. The patient was experiencing paranoid delusion. These factors for brain psychotic disorder include stressful life events and personality disorders. Treatment may include hospitalization and antipsychotic treatment depending on symptom severity and functional impairment. Those on symptoms or the entire presentation may resolve without medication. Okay, so it can be triggered by stressful life events and personality disorders. Okay. Adjustment disorder with mixed disturbance of emotional and conduct refers to the onset of disproportionate distress within 3 months of an identified with stressor with associated anxiety, depression, and conduct disturbance. Psychotic symptoms will be atypical. Okay, so adjustment disorder, there's no psychotic symptom. And then substance-induced psychotic disorder refers to psychotic symptoms secondary to substance abuse. Alcohol use rarely leads to directly to psychotic symptoms, though heavy cannabis use can lead to psychotic symptoms. This patient cannabis use is intermittent. Okay.
Okay, next. A 37-year-old man who is a federal prisoner admitted to the hospital because of 4-day history of increasing shortness of breath. The patient has a history of hepatitis C, traumatic brain injury, stimulant opioid use disorders that can both now in remission. He was shortness of breath. He was sorry. Mm, the patient makes 5 objects after 5 minutes. He accurately recites the months of the year backward and is active 5 digits forward and backward. He refuses to complete a clock and exercise the interpret verb. Further evaluation discloses there is aortic regurgitation and infective endocarditis. The patient will also recover within 6 months with IVIG and aortic valve replacement. She depends on. Okay. Uh, the,
Ready?
yes.
Hmm. Determine the patient's informed decision-making capacity. Patients who are making high-stakes or risky medical decisions, declining life-saving procedures should be informally evaluated for decision-making capacity. These patients demonstrate abnormalities in cognitive testing and has risk factors for cognitive impairment, including traumatic brain injury and prior illicit drug use. Um, Cognitive impairment confers a higher risk for lack of decision making capacity. To meet criteria for decision making capacity, patient must express a consistent choice, demonstrate an understanding of the risks and benefits of the choice, demonstrate an appreciation of the significance of choice for the personal circumstances, and illustrate an ability to reason through the option. A medical team should assess the patient decision-making capacity for each decision at each point in time. If decision-making capacity is present, the medical team should respect the patient's choice. If decision-making capacity is absent, the medical team should first try to restore decision-making capacity, like great psychosis. If decision-making capacity can be restored, then the medical team cannot be restored. Medical team needs to rely on substitute judgment from durable power of attorney of next of kin. It's not the B or E. The fair decision to prison authorities unethical. Prison authorities involved in the question punishment should play no role in medical decision making. The decision the patient to come for care only is premature. The medical team should first assess the decision making capacity to decline the aortic valve replacement procedure. Next.
Okay. An 87-year-old man who resides in a skilled nursing care facility is brought to the physician by staff nurses because of increasing anxiety during the past 2 days. They report that he frequently uses his call bell and requests medication. 1 week ago, he was prescribed lorazepam 1 milligram as necessary for nervousness. Since then he has requested if there are For if they are wired 4 times daily, he states that the recent addiction of lorazepam alleviates his pain only mild only, and seems to make more tired. He is exhausted all the time, but does not have difficulty in falling asleep. He has a decreased appetite and his decreased appetite and he has he says that no Christ, okay. So which of the following is the most appropriate one? Okay, ready?
Sure. Yes. It is discontinued lorazepam instead mirtazapine. Lorazepam benzo with short life half-life can lead to rebound anxiety, resulting in this patient increased lorazepam use. Although lorazepam commonly leads to delirium in all the patient, thus lorazepam should be stopped. This patient who reports a sad mood, insomnia, decreased appetite, decreased energy, decreased motivation, likely has MDD. MDD is characterized by 2 or more weeks of at least 5 of the following. We know that these symptoms exhaust everyday functioning. Patients commonly have negative thoughts about negative thoughts about themselves, others, and the world. Patients seeing themselves as a burden also constitutes an acute risk factor for suicide. All the men are at particularly high risk of completing suicide, so these patients should be carefully evaluated for suicide ideation. Many depressed patients engage in anxious rumination. MDD that includes anxiety symptoms can be termed as MDD with anxious features. Um, Initial antidepressant medication for most patients is SSRI. However, professionals with the combination of decreased appetite and insomnia, metazapines are not the reason of the first line option, given the adverse effect profile that includes weight gain and sedation. Metazapine, atypical antidepressant, is a selective alpha 2 receptor antagonist and serotonin modulator. It's not increase the dosage of lorazepam is unlikely to be helpful and is likely to worsen the patient with anxiety and delirium risk. Next.
Okay. A 20-year-old woman is brought to the emergency department by her parents 30 minutes after being unresponsive. Her temperature is 36 degrees Celsius, pulse 135 per minute, respiration 20 per minute, and shallow. Pulmonary systolic blood pressure is 60 per minute. Physical examination shows no abnormality. Neurological examination shows no focal findings. His blood glucose is 20 milligram per deciliter. Her C protein is subprotein concentration is decreased. Which of the following is the most likely diagnosis?
Ready?
1 second, please.
Okay.
Okay.
Okay. So it is exogenous hyperinsulinemia. Decreased C-peptide concentration indicates that the exogenous insulin is being administered consistent with A diagnosis of factitious disorder: the pancreas co-produces insulin with C-peptide. Measurement of C-peptide concentration can be used to diagnose diabetes mellitus and distinguish type 1 from type 2. It can also be used to in diagnosis of factitious hypoglycemia when a patient may be subjected or self-administering insulin. Those serum insulin concentration will appear increase and blood glucose will be decreased. Negative feedback on the pancreas decreases production of C-peptide and active insulin. In factitious disorder, patients consciously produce symptoms, fake fever, injure themselves for primary gain. Primary gain is the motivation to be careful, which constitutes an unconscious motivation for the patient conscious but earlier early losses, neglect, and abuse may disrupt patients' identity and relationship. And adopting the syndrome may represent patients attempt to cope with stress and stabilize their identity. Side comorbidities like depression, substance use person are common but not present in all patients. Diagnosis is supported by inconsistencies in the history and physical exam and a history of extensive clinical evaluation. Treatment includes regular follow-up with one physician who oversees management as opposed to symptom-triggered appointments and possible psychotherapy. Next.
Yes. A 23-year-old woman comes to the clinic for a follow-up visit to request a refill of her oral contraceptive. She usually she is sexually active with two male partner, has been unable to have vaginal intercourse because of pain. She experiences anxiety and anticipation of the sexual activity and feels that her pelvic floor muscles contract and prevent vaginal penetration. Mm, she also used vaginal tampons.
Ready?
Yes.
Is vaginismus. This patient likely has vaginismus and involuntary muscle spasm during vaginal penetration. Patients who are defined as having difficulty with vaginal intercourse, genitopelvic pain, fear of vaginal penetration or pain, and increased pelvic floor muscle tension during attempted penetration. These factors include a history of abuse, anxiety disorders, relationship conflicts, and cultural taboos. Vaginismus can also happen secondary to vulval infections, like candidiasis, gynecological problem in the middle of pregnancy. Physical exam is typically normal other than pelvic floor muscle tightness. Treatment is multimodal and commonly involves pelvic floor physical therapy, physiotherapy like CBT, psychoeducation, and topical pain medication. It's not E. Vulvodynia refers to vulvar pain, burning or stinging of a non-etiology, no vaginal pain. This patient is not this, this pain is not typically provoked by vaginal penetration.
Okay.
Next.
Next. A previously healthy 23-year-old man is brought to the emergency department by friends 20 minutes after the onset of bizarre behavior that begins at a party. His friends say that he became paranoid and started threatening him. Her temperature is 103 degrees Celsius. While the physical examination show agitation, diaphoresis, horizontal knee tightness, occasional myoclonus, mental studies, examination show these are tricks, speech combativeness. His thoughts are disorganized. He is unable to give a coherent history. He believes that the physician is trying to kill him. 30 minutes later, he becomes somnolent. Administration of naloxone does not improve this condition. Which of the following is the most likely diagnosis? Nystagmus. Nystagmus for PCP.
Mhm.
Okay.
So is PCP uh, NMDA glutaminergic receptor antagonist that's used recreationally for its euphoric inducing a dissociative effect. PCP intoxication is often characterized by signs and symptoms of hyperthermia, hypertension, tachycardia, erratic behavior, paranoia, psychosis, aggression, decreased sensation, ataxia, nystagmus, myoclonus, dysarthria. Patient may require sedation, treatment with antipsychotic medication, or physical restraint until the symptoms stop. Withdrawal symptoms following with PCP intoxication are common. Naloxone has no effect on PCP. Next.
A 24-year-old woman is brought to the emergency department by police because she has been shouting obscenities at a rental car agent. Police report that the agent called them for help because the patient became out of control when told them the company did not have luxury sports car rentals. She is employed as a receptionist at the local at a local accounting firm. Physical examination showed no abnormality. During the examination, the patient asked for the physician's phone number and winks and says, really saw I could really show you a good time." She attempts to kiss the physician. On mental state examination, she has agitated declares that she's absolutely fantastic and her speech is loud and rapid. Okay.
Oh, um, Victor.
Is it histrionic or is it bipolar?
Yeah, that's why I'm between both also. So she's using sexuality, but then also her speech is like she tried to
Yes,
kiss the doctor, but her speech is also
loud.
yes, I go with yeah, it's rapid, yeah, rapid and loud.
Okay, let's see.
Let's see, I guess it will go more with bipolar. Yeah, bipolar. This patient is experiencing an episode of mania and can therefore be diagnosed with bipolar. Bipolar is a mood disorder that features acute episodes of mania and may include depression. Good mania typically manifests with irritable, euphoric mood, increased energy, decreased need for sleep. This goal directed at rapid speech, thinking, responsibility, like trying to please the doctor and overspending, and grandiose thinking. Some patients demonstrate associated psych symptoms like hallucinations. Acute manic can severely disrupt patient daily function and endanger the safety. Management of acute mania typically requires more stabilization or atypical antipsychotics. And it's not histrionic. Histrionic personality disorder characterized by theatrical, superficial expression of emotions that unconsciously serve to garner attention from others to fulfill emotional needs. Personality disorder symptoms are chronic and pervasive, whereas this patient seductive behavior is occurring in the setting of acute mania episodes. Okay, next.
Okay. A 35-year-old man is brought to the emergency department. 35-year-old man is brought to the emergency department by paramedics who were called by his neighbor who reported he was speaking nonsense and holding example. The patient appears lethargic and falls asleep, and multiple times on arrival of the emergency department, the patient's speech is rambling. He is not oriented to place or time. He is cooperative, but occasionally and mildly agitated until the interviewer clarifies where the patient is and what is happening. The patient describes a visual hallucination of a mice crawling up the wall. He has no history of hypertension for which he takes amlodipine. The patient does not use illicit drugs and drinks two alcoholic or beverage daily. Temperature is 40 above 100 per minute. Respiration 20 per minute. Blood pressure 140 by 80. Pulse oximetry on room air shows oxygen saturation 99%. Abdominal examination discloses right upper quadrant tenderness. Mental status examination shows decreased attention, concentration, impaired new memory formation ability, which is the most likely diagnosis. In schizophrenia or schizophrenic form, there is auditory hallucination, isn't it?
Mm-hmm.
Uh, then the delirium.
Go
Ready?
without. No, between alcohol and
Alcohol and
delirium.
delirium. He has no any other infection apart from alcohol.
The
Does
human drinks two beverages daily. Doesn't make sense for alcohol.
why fever?
Why fever?
In alcohol withdrawal, there may not be fever, isn't it?
Uh, I don't think it may be, but I don't think that's. But he's in and out of the thing. Probably delirium. He's in and out of the thing. I think that's the key. Let's see. If not, it's alcohol withdrawal. Okay, yeah, it's delirium. Delirium is an acute confusion of state typically resulting from acute medical illness, sleep disturbance, substance use, medication. Delirium is especially likely in all patients who possess a decreased cognitive reserve, though it also likely in young patients with acute mental illness, medical illness, as in this patient with a high fever and right upper quadrant abdomen who may have a serious infection such as acute cholecystitis or cholangitis. Delirium presents with acute disturbance in awareness, attention, and baseline condition that fluctuate in severity during the course of the day. Patients may present with perceptual disturbance like hallucination and delusions. Management of delirium should focus on treatment of the underlying medical condition. If one is detected, frequent orientation, maintenance of sleep-wake cycles, and placement of the patient in a calm-soothing environment. Non-alcohol withdrawal. Um, Alcohol withdrawal can present with acute confusion in the case of delirium tremens. Delirium tremens typically present with autonomic instability like tachycardia, tachypnea, hypertension, hyperthermia. Okay. Tremors, anxiety, hallucination, confusion, delirium, and ataxia may result in convulsions, coma, and death. Where this patient moderate use of alcohol is unlikely to lead to severe withdrawal symptoms. Yeah. As well, the patient has the localizing symptom of abdominal pain in addition to fever. This is which suggests acute abdominal infection like hepatitis. Okay.
Okay. A 7-year-old boy is brought for a well child examination. His mother says that a high energy he has a high energy level and sleeps only 6 hours nightly. He has been expelled from to daycare center and is unable to read or pay attention. In the first grade, he has no friends. He has a history of frequent accident and has previously been treated for sprains or lacerations. He is at 50 percentile for height and weight. His Vital signs are within normal limits. Physical examination shows large ecchymosis over the right knee. During the examination, he picks up his nose. Lab examination should the most administered.
Maybe
1 second, please. Okay.
okay, so it is parent and teacher behavior rating scales. ADHD is a heritable neurodevelopmental disorder that presents with chronic symptoms of hyperactivity, impulsivity, and or inattention that occur in more than one setting and impair academic, social, or emotional function. Children with predominantly hyperactive symptoms are unable to sit still and may have difficulty with impulse control, resulting in movement initiation without planning and consequent injuries, as in this patient. Most patients with ADHD may demonstrate body focus activity, nose picking, skin picking to relieve their in a sense of restlessness. Children with predominantly inattentive symptoms tend to daydream, process information, store and have difficulty completing tasks. These patients demonstrate predominant hyperactive symptoms for diagnosis. Physician must establish that the patient is functionally impaired in several settings. So parents and teachers must fill out behavioral rating scales. Stimulants which include amphetamine salts and petipenidet as first line um, for treatment that increase synaptic dopamine and norepinephrine. Sleep problems including comorbid insomnia and stimulant-induced sleep problems are common in patients with ADHD. It's not COD. X-ray, X-rays of the lung bone for fractures that possess history of child abuse. This patient has symptoms of ADHD which will explain the frequent injury. Clotting factor help assess bleeding disorder. The patient ecchymosis is more likely due to impulse dysregulation in the setting of ADHD. Next.
Okay. A 42-year-old woman is brought to the emergency department by police 30 minutes after she was arrested for throwing trash on her neighbor's lawn and yelling at them. On arrival, she is indignant, alert, and fully oriented. She says her neighbors are harassing her and talking about her behind her back. She noticed she has moved twice, and each time her neighbors have followed her to new location. The patients say they spoke to the neighbors and who have lived in their home property lines. The patient has stable work history and has a retail clerk. She has no history of serious illness, no medication, and physical examination shows abnormality. Mental status examination shows an angry mood. She has a full range of affect affected due to non-disturbance.
Oh, frustrating. She is paranoid. Hmm. Ready? Am I?
Yes, I'm there.
Okay,
Okay.
sorry.
Red,
It was too
ready.
quiet. It's delusional disorder. It's delusional disorder. It's hard to pick. Delusion disorder is a psychotic disorder that features the presence of one or more delusions for 1 month or longer with no other psych symptoms like hallucination, disorganized thinking, organized behavior other than the delusion or mood symptoms. Patient lack other signs of severe thought disorders such as cognitive impairment, as evidenced by this patient appropriate abstract interpretation of a problem, an affect that is incongruent with the topic of conversation. Persecutory delusions, persecutory delusions and somatic delusion are common type of delusion. Many patients will only present for care at the insistence of other people given the lack of insight into the psychotic nature of the consent. Treatment typically includes antipsychotic medication and psychotherapy, with the goal of improving the patient coping with the delusion and gradually increasing insight into the delusion. Prognosis is guarded. It's not paranoid personality disorder because characterized by pervasive mistrust of others and viewing others as possessing malicious intent. Personality disorders typically begin in young adulthood. These patients' psych symptoms develop in middle age, which is inconsistent with personality disorder. Schizophrenia is a chronic psychotic disorder characterized by delusion, hallucination, disorganized speech, organized behavior, negative symptoms. This patient demonstrates an isolated delusion with no disorganized speech, thinking, hallucination, or negative symptoms. She also has cognitive impairment, which is schizophrenia. Okay. Next.
Hmm, okay. A 23-year-old woman comes to the office for a follow-up examination. She was evaluated 1 year ago for an initial major depressive episodes and began fluoxetine therapy. She says that her depression will well control and notes increased enjoyment of social activities and greater productivity at work. She reports no suicidal ideation. The patient is concerned because she recently started a new relationship but has limited sexual desire. Her vital signs are within normal limit. On mental study, the examination, the patient is smiling and has a euthymic effect. Which of the following is the most African mixed element?
Ready?
Yes.
Decreased dose of fluoxetine. Increased serotonin likely explains this patient's sexual dysfunction. Fluoxetine is a SSRI, increases synaptic serotonin activity and improves mood in patients with MDD. SSRI commonly cause sexual dysfunction with all three stages of sexual response. If a patient decreases libido is persistent and distressing, initial management commonly involves decreasing the SSRI dose, especially if depression has been sustained remission. If this is ineffective, then the physician can consider discontinuing fluoxetine. Since this patient depression has been in sustained remission and has only experienced one depressive episode. If the patient prefers to stay on antidepressant medication to prevent future depressive episodes, then ibupropion is switching to an antidepressant with lower risk for sexual dysfunction like bupropion or mirtazapine will be reasonable. It's not the where was that? C. Initiate sildenafil is unlikely to be helpful. Sildenafil can be Effort in treating antidepressant-induced arousal problem and anorgasmia, but has not been shown to affect libido. And replacing fluoxetine with escitalopram is unlikely to resolve this patient SSRI-induced sexual dysfunction because citalopram carries the similar risk for sexual dysfunction compared to depression. Okay.
Next.
We take a quick break.
Okay.
I can get my breakfast. Thank you. Thank you. Okay,
Okay.
ready. Let's finish this today.
Yes. A 25-year-old woman comes to the physician because of 2 month history of episode of sudden anxiety. During this episode she had chest pain, shortness of breath, palpitation, fear of losing control and going crazy. The episodes occur several times weekly and come out of the blue. She has not been depressed and has changes in sleep pattern or appetite. She is 170 centimeter tall, weight is 60 kg, BMI is 21 kg per meter square. Her pulse is 88 per minute, blood pressure 130 by 86. Physical and mental status examination showed no abnormality. Lab findings are within reference. Urine toxicology is negative. The physician is most likely to have which of the following abnormalities?
Ready?
Yes,
So it's increased sensation to lactate infusions. Panic attack features acute fear of anxiety that peaks within minutes associated with four additional physical symptoms. These additional symptoms may include palpitation, tachycardia, shortness of breath, and all that. Panic disorder and anxiety disorder characterized by recurrent panic attacks that are unexpected and associated with worry about future panic attacks and avoidance of panic attack triggers. Pathogenesis involves genetic factors and anxious temperament and stressful life events leading to catastrophic appraisal of internal body states such as normal sympathetic activity. Lactate infusion recreates states of bodily stress. It has been found that patients with panic disorder experience panic attack in response to lactate at an increased rate compared with the general population. However, there is an absence of standardized criteria to lactate-induced panic attacks, so the diagnosis utility is unclear. Treatment of panic disorder typically includes antidepressant medication and CBT with a focus on decreasing patient catastrophic appraisal of bodily sensation of sympathetic arousal and increasing patient's ability to cope with panic attack sensation. It is not abnormal eye tracking. It's found in patients with schizophrenia, patients with panic, yeah. And then non-suppression of cortisol after administered dexamethasone is consistent with Cushing syndrome, not panic attack. Okay,
okay.
next.
Next. A 37-year-old man comes to the physician with his wife because of 4 nocturnal episodes of violent behavior during the past 3 months. His wife reports that she awake to hear him shouting. During one episode, he tried to choke her. She no longer sleeps in the same bed with him. The patient does not recall these episodes. He does not snore or have daytime fatigue. He has no history of serious illness and takes no medication. There is no family history of similar behavior. He does not drink alcohol or illicit drug. Physical examination shows no abnormality. Mental status examination shows youth, high make, mood, and reactive effect. He is alert and oriented to person, place, or time. Which of the following is the most likely diagnosis?
Ready?
Sorry?
Ready?
Yes.
So
Yes.
it is REM sleep behavior disorder. Um, in typical REM sleep, several neurosecrets terminate on spinal cord motors to cause atonia. This muscle atonia is lost in REM sleep behavior disorder, in which patients typically violently act out their dreams. They typically, but not always, remember the dreams. REM sleep behavior disorder most commonly occurs in adult males and can be idiopathic or related to underlying alpha-synuclein deposition like Parkinson, multiple system, or Lewy body dementia. Polysomnography showing obscene atonia during REM sleep confirms the diagnosis. Treatment includes creating a safe sleep environment, and if behavior is severe, initiating melatonin and clonazepam. Patients with idiopathic REM sleep behavior disorder should be closely monitored due to the high rate of developing neurodegenerative disorders. C is not C. D. Let me see. Nighttime nightmare disorder describes the presence of recurrent disturbing dreams. This patient makes no report of disturbing dream activity, though such can be inferred from his behavior. While his dreams may be nightmare, the absence of sleep atonia makes REM sleep behavior more likely. Nocturnal panic attacks occur during the night and wake up the patient. This patient is still at sleep while acting out the dreams. Okay.
Next. An 8-year-old boy. An 8-year-old boy is brought to the physician by his mother because of 1 year history of worsening behavior problems. 1 year history of worsening behavior problems at school and at home. His teachers report that he has difficulty following room. He has difficulty following rules and is often angry and volatile. He argues frequently with his teachers and annoys others deliberately and blames them for his own mistake. His behavior has been uh, uh, his behavior has begun to affect his school performance, and his mother has been told that he may need to repeat second grade. His mother says that he also argues with her at home and refuses to follow the house rules. She is single, unemployed, and has several live-in boyfriends during the past year. His older brother recently dropped out of the school, and child receives supervision at home. His adequate concentration and normal appetite. He sleeps 9 hours each night. Physical examination showed no abnormal cells showed neutral mood, normal thought processes. He is belligerent. Which of the following is the most appropriate initial treatment for this patient?
Okay.
Ready?
Yeah. So it's parent education and training. Oppositional defined disorder is a childhood disruptive behavior disorder that manifests as a persistent pattern of angry, irritable mood, defined behavior, arguing with or defying authoritative figure, blaming others for the own mistake, and vindictiveness. These behaviors cause dysfunction in the patient's immediate social context and lead to educational and professional dysfunction. This patient demonstrates defined behavior towards parent, teacher, and physician. Positional defined disorder commonly arises from a combination of genetic factors, irritable temperament, sometimes childhood neglect or harsh parenting style. Comorbid ADHD, learning disorder, anxiety disorders, and substance use are common. Management is multimodal and include parent management training, teaching parents to reinforce positive and negative punish behavior, school-based intervention, and individual anger management therapy. Is not B or C. Or insight-oriented psychotherapy and psychoanalytic psychotherapy both attempt to uncover unconscious thoughts and feelings that drive present-day behavior and relationship. Present-day, okay. Young children are likely to have a reflective capacity to gain insight into the unconscious motivations. Okay.
Next. A 23-year-old man comes to the clinic because of 3-month history of sexual dysfunction and nightmares. The patient serves in the US Army Reserve and says the nightmares began after returning from the recent deployment in the combat zone. He reports experiencing generalized anxiety, intrusive thought, nightmare, hyperarousal, and stimuli that remind him in the military service. He also says that he has experienced moderately depressed mood during the past month. During sexual intercourse with the girlfriend, he typically ejaculates within seconds and causing embarrassment. The patient is open any suggestions for treatment or any try medication if it would help. Vital signs are within normal limit. Which of the following is the most appropriate for? It is premature ejaculation, isn't it?
Yeah. Ready?
Ready? Yes.
Oh, it's paroxetine. Mm, mm, mm. This patient demonstrates premature ejaculation, a type of sexual dysfunction. Psychological factors such as performance anxiety, marital conflict, and PTSD can exert strong influence and sexual function. In males, anxiety can lead to decreased libido. In male, anxiety can decrease libido, decreased ability to obtain or maintain erection, premature ejaculation, decreased ability to ejaculate. Treatment strategy for sexual dysfunction inclusivity, mindfulness, meditation, training, and pharmacotherapy. First line pharmacotherapy for premature ejaculation is SSRI therapy, particularly paroxetine. SSRI have an unclear mechanism for delaying ejaculation that likely involves descending serotonin pathways. Patients with PTSD experience intrusive thoughts, memories, nightmares, flashbacks, dysregulation of arousal, irritability, angry outbursts, blah, 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 avoidance of reminders, and negative mood thoughts. SSRI are also first line for PTSD. Okay, so what was the question? Pharmacotherapy for the sexual dysfunction, and the PTSD. Okay, and it's not bupropion, antidepressant that increases norepinephrine and dopamine. Bupropion has small amount of evidence for the treatment of premature ejaculation, but SSRI have more evidence for their effectiveness. As well, bupropion has no proven efficacy for PTSD. Okay, fine. Mirtazapine a typical antidepressant medication is whatever. It has not proven efficacious for premature ejaculation. Okay. Okay. Next.
Next, a 43-year-old man is hospitalized for treatment of superficial frostbite of his toes. He had been found by police 5 hours ago, wandering in a snowstorm shoes. He claims to be God and to have the power to melt the snow and purify the earth. He correctly identifies the date and his location. He is asked to remember three words: red penny train. He laughs and playfully responds, color conveys. His speech is rapid, incessant. He paces the examination room. His arms are extended overhead, index fingers pointing towards the ceiling. Which of the following is the most likely diagnosis? Ready?
Yep.
Okay.
So it's bipolar. Experiencing acute episode of mania and can therefore be diagnosed with bipolar mood disorder that affects that features acute mania and depression. Some patients demonstrate associated psychotic symptoms. Those mania can severely disrupt patients' daily function and endanger the safety. Management acute mania, mood stabilizer, or atypical antipsychotics is not break psychotic and characterized by at least one acute psychotic symptom lasting less than a month. The patient's psychotic appear to be secondary to mania. It's not delirium. Well, refers to alcohol withdrawal that typically presents with autonomic stability, tremors, blah, blah, blah. This patient has normal vital signs. It's not delusional disorder presents with fixed delusion in the absence of other psych symptoms like hallucination, depression, whatever. It's not schizophrenia presents with at least two of the following. This patient does not demonstrate negative symptoms. Okay, next.
Okay. A 17-year-old girl is brought to the physician for a follow-up examination. 1 week after being raped by an unknown assailant, she has she has had flashback of the rape and difficulty sleeping, nightmares, early morning awakening, and impaired concentration. She has not been able to go to school and avoid the neighborhood where the rape occurred. She is tearful, thoughtful in the interview and says she feels depressed and guilty. She says she is easily frightened and does not leave the house at night. She feels like she is in a daze and detached from herself or others. Occasionally, she feels like she is having an out about experience and has feelings is unsteady. Which of the following is the most likely diagnosis?
Ready?
Yes.
Acute stress disorder (ASD) presents similarly to PTSD with intrusive thought memories, dysregulations of arousal, avoidance of reminder, negative thoughts and moods in response to violence or threatened violence. Like PTSD, patients can also experience dissociation with mm, the mind attempt to decrease conscious awareness of painful effects, blah, blah, blah. However, ASD presents within 1 month of traumatic event. PTSD is more than 1 month. ASD typically lasts between 3 days to 1 month. Pharmacotherapy is typically not needed. The trauma-focused CBT may be helpful. In this case, providing normalization about the range of reaction to trauma and education. When to seek psych help will be most helpful. Next.
Yes. A 22-year-old woman is brought to the emergency department by police 1 hour after she yelled continuously at the security guard in a shopping center. On arrival, she is angry. She says that she has been fighting with her she has been fighting with her parents and during the past 2 days because mm, they are out to get her. 10 days ago, she was admitted to the hospital after attempting suicide and cutting her wrist. She was diagnosed 1 week ago. She was discharged 1 week ago. She is 157 centimeter, weight 45 kg, BMI 18. Her temperature is 37, pulse 112 per minute, respiration 18 per minute, blood pressure 154 by 92. Physical examination shows multiple excoriation over the upper extremity and well healing wounds over the wrist. On examination of the mouth, the teeth are stained. The teeth are stained. Several bugs and wants to die. Which of the following is the most likely diagnosis? Uh,
Oh, interesting.
Sorry,
I'm trying to find what is the teeth that stain, blah, 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 and teeth are missing.
bug crawling happens in which? Alcohol, liquid control.
The what? Can't hear you.
Like bugs crawling, isn't it?
Back scrolling, yeah.
This is the key
Is it?
point. Is it
Yeah.
marijuana or is it
Or is
alcohol?
it? I don't think it happens in alcohol. Does it happen in alcohol? I don't think so. Methamphetamine or cocaine, methamphetamine. Oh my lord, I don't know. Tactile stimulation, back scrolling. Oh
Okay,
my
pick
lord.
something.
Okay, okay, okay. I'll go with methamphetamine, which I'm pretty sure is not that. Okay, let's see. It is, yeah, it's methamphetamine intoxication. This patient is studying intoxicated with methamphetamine. Amphetamines are CNS stimulants that cause euphoria, increase sympathetic tone due to increased catecholamine concentration. Leading to tachycardia, hypertension, hyperthermia. He doesn't have hypertension. Pupillary dilation, diaphoresis, agitation, restlessness, appetite suppression, and weight loss. Patients with chronic methamphetamine use often have periodontal disease, such as stained teeth, cavities, or missing teeth. Chronic methamphetamine use um, can also lead to methamphetamine use height disorder, which features chronic delusions, paranoia, hallucinations, tactile or visual hallucination of parasites may occur. It is not alcohol use. Alcohol intoxication can cause slurred speech, emotional liability, behavioral disinhibition, ataxia, and memory lapses. In severe intoxication, stupor and respiratory depression can occur. Alcohol withdrawal causes anxiety, the tremors, diaphoresis, nausea, vomiting, and hallucination. Complicated alcohol withdrawal refers to severe life-threatening that causes seizures and delirium tremors. It's not, what was that the other one I was confused about? Marijuana intoxication causes euphoria, paranoia, hallucinations, cognitive slowing, eye redness, and dilated pupils. Patients withdrawing from marijuana experience irritability, anxiety, depression, insomnia, decreased appetite. Okay, so intoxication of marijuana is increased appetite and eye redness. Um, Withdrawal is decreased appetite and insomnia, restlessness, whatever. Methamphetamine withdrawal typically leads to sedation, fatigue, and increased appetite. Okay, next.
Yes. A 37-year-old woman comes to the emergency department because of feeling of sadness and thoughts of the suicide for one day. Her symptoms began after an argument with her boyfriend over the fact that she told she sold his television set. When he becomes angry, she threatened him with a gun and that said that she would hurt him. She is currently probation after incarceration for assault. She has no history of serious illness, takes no medications. You
Ready?
Yes.
Okay, so it's antisocial personality disorder. Antisocial personality disorder arises from a deficit in empathy, resulting in pervasive violation of other rights, aggression, and hostile and manipulative attitude towards others. Manipulative, okay. Like other patients with antisocial anxiety struggle to regulate their emotion in that their frustration tolerance is low. They frequently behave impulsively. It is postulated that genetic polymorphism in the serotonin transporter gene lead to deficient serotonin signaling and causative dysphoria. Some studies have identified a higher than average rate of suicide among patients with antisocial personality disorder, which may be related to negative emotionality, hostility, and low restraint. These patients may also be chronically bored and hence sensation seeking, leading to a high rate of substance use and gambling. This personality traits lead to deficits in personal and interpersonal functioning. Personality disorder are persistent maladaptive way of relating to self and society that typically appear by early adulthood. It's not F. Substance-induced mood disorder refers to depression symptoms secondary to substance use. This patient has taken her son methylphenidate in the past but is not currently using any substance.
Next. A 75-year-old man is brought to the office by his wife 1 year. History of progressively worsening memory for more frequent falls. The patient reports Also experiencing intermittent episodes of urgent continence several times throughout the week. He has not interest in usual thoughts and is described by his office at Moody. Sorry. The wife reports that someone altogether she can use a cane. The patient's wife has to take over paying household bills. Takes keep forgetting what happened. The patient hypertension, diabetes, okay, everything. Recall three of the three objects immediately. One to three objects over 5 minutes unable to perform serial 7. Which of the following? Ready?
No, no pressure at the cephallus is ataxia, urinary incontinence, and I don't remember what was the other. So is it normal pressure at the cephallus? Okay, right.
Okay.
Okay, it's normal pressure hydrocephalus. Normal pressure hydrocephalus (MPH) refers to type of communicating non-obstructed hydrocephalus in which the ventricles are enlarged due to damage of the white matter. Tracts connecting the frontal lobe and basal ganglia. MPH typically present in older men with insidious onset of dementia, gait apraxia, urinary incontinence. The gait apraxia may manifest a wide-based and magnetic gait. The central vestibular tract, a white matter tract located in the periventricular area, may also be affected by ventriculomegaly, leading to patient postural instability. Signs to increase intracranial pressure, papilledema, posterior headache are typically absent. Many patients with MPH are idiopathic, um, though some are secondary to defect in cerebrospinal drainage from the ventricle due to scarring obstruction of the ventricular lining from hemorrhage or meningitis. The diagnosis is primarily clinical, although ventriculomegaly on brain imaging is suggestive. Patients may improve rapidly in response to drainage or CSF during a lumbar puncture, which supports the diagnosis. Management is commonly includes ventricular shunting for patients with a positive lumbar tap test. It is not dementia vascular type, also known as multi-infant dementia, presents with a stepwise decline in cognitive performance over several years and focal neurologic deficit. It occurs as a result of cumulative damage from many small ischemic stroke, and so X-rays often show evidence of microvascular disease. The gradual onset of this patient declines as well as his gait changes. Urinary symptoms have more suggestive of MPH, and it's not so the dementia secondary to MDD can be observed in all the patients, but this patient does not demonstrate adequate criteria for the diagnosis of depression, such as depressed mood and blah, 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 blah. Okay, next.
The final one. A 9-year-old boy is brought to the office because he was refused to eat meals with family during the past month. His grandmother, who noticed, uh, who recently visited and noticed that she has lost weight. Her mother started a new job 6 months ago and has been working long hours. She says that although he has always been a warrior, he has been negative and irritable during the past month. He often plays to do his household chore after postponing them. He has become withdrawn. He has become more withdrawn, and he quit basketball team. And he quit the basketball team. His grades in the school has dropped B to D. On recent, He recently told his mother he wished they are dead. He had complaint of stomachache, occasional. Uh, okay,
Mhm. Ready?
okay,
Okay. It's MDD. MDD, this patient meets criteria for MDD, 2 or more weeks or at least 5 of the symptoms. Before patients commonly demonstrate negativistic thinking about themselves and others and the world. Symptoms disrupt everyday functioning, low grades, home dysfunction, social withdrawal. Additional somatic symptoms such as stomach aches are common. Prominent mental status exam findings commonly include depressed affect with a decreased affective range and latent skill. Patients with MDD should be assessed for suicidal ideation. The most effective treatment for MDD includes combination of psychotherapy and antidepressant. It is not borderline personality disorder, features emotional dysregulation and an unstable sense of self and tumultuous relationship. Um, which one? This patient is experiencing a consistently depressed mood, not a dysregulated fluctuating mood or superficial emotions, as well as official personality disorder diagnosis require the patient to be 18 years old or older. Is not, it's also between age, there is age. It's not somatic symptom disorder. Patient excessively worried with one or more somatic symptoms, such that these symptoms disrupt daily life. This patient is not preoccupied with his stomach ache. That's it. We're done.
okay,
I'll see you tomorrow.
okay. What what?
We only have emergency medicine, so it will be emergency medicine one.
Okay, okay. Bye bye.